So what are the valvular lesions present in acute rheumatic carditis? Well, you can classify them into 3 different points: the presence of Aschoff bodies, the thickening of the valves, and the presence of vegetations along the leaflets of the valves. Aschoff nodules or bodies are pathognomonic of acute rheumatic fever. They're spheroidal or fusiform in shape with a small diameter, and they're found in any layers of the heart, particularly in the small blood vessels within the myocardium and the endocardium. Although they are present in acute rheumatic fever, they later get replaced by collagenous scar tissue in chronic rheumatic heart disease. The Aschoff bodies go through 3 stages of development. The first one is the early stage or the exudative or degenerative stage, the intermediate or proliferative or granulomatous stage, and finally the late healing or fibrous stage. By the 4th week of the fever, there is edema of the connective tissue and acid mucopolysaccharide, which causes collagen fibers to become separated. The collagen eventually gets fragmented and disintegrated and takes up the appearance of fibrin and its staining characteristics as well. This change is referred to as fibrinodegeneration. Following the degeneration, there's an infiltration of lymphocytes, plasma cells, some neutrophils, and cardiac histiocytes called Anischkow cells at the end of the lesion. These cells have an abundant cytoplasm with nuclei and a wavy condensed chromatin in the middle, which are referred to as caterpillar cells. These cells can later modify into Aschoff giant cells, which are multinucleated. 12 to 16 weeks after the illness, there is a healing process that's undergone by the fibrosis of the Aschoff nodule. It becomes oval in shape, and the Anischkow cells inside it become spindle-shaped with a diminished cytoplasm. In several months to years, the Aschoff body eventually becomes more collagenous than before and is replaced by fibrocollagenous scar tissue. In acute rheumatic fever, the valves will appear to be thickened and the leaflet or the cusp of the valves will have lost its translucency. This effect is further seen in chronic rheumatic carditis. Following this, small inflammatory vegetations will line along the leaflets, which gives it a regular appearance. These are caused by the erosion of the valvular surfaces, which causes the fibrin and platelet. The vegetations in rheumatic heart disease are much smaller, they're gray-brown in color, translucent, and are firmly attached, unlike in infective endocarditis, which makes it highly unlikely for them to form an embolism by detaching. As the inflammation gets resolved, scarring can occur as a result. Although all the valves are affected, the most common ones are mitral valves. As shown here, they're most commonly found on the mitral valve and the aortic valve more than the other two.